So I'm Professor Paula O'Brien from Melbourne Law School, and I warmly welcome you to today's seminar at Melbourne Law School. We meet today on the land of the Wurundjeri people of the Kulin Nation, and I pay my respects to elders past, present and emerging. So today's seminar is presented by the Health Law and Ethics Network, which I co-direct with Chris Gingell from the Murdoch Children's Research Institute, who is here with us. And today's topic is what matters most, a legal ethical analysis of reasonable inquiries in obstetric care. And we're really pleased to welcome today Dr Naomi Holbeach and Shanee Katz. So Naomi is an obstetrician gynaecologist, and she's dually trained in law and medicine. And so she has also finished a PhD in bioethics. She's a senior lecturer and the academic coordinator for learning and teaching in the Department of Obstetrics, Gynaecology and Newborn Health at the University of Melbourne. And Shanee Katz is a final year medical student, and she completed her final year thesis on the topic that's being presented on today. And she was supervised by Naomi and myself. And so congratulations to Shanee on her thesis as well. So Shanee and Naomi are going to present for maybe 35, 40 minutes, and we'll certainly have some time for questions at the end. And you're welcome to pop questions in the chat as we go, or to turn on your hands up and turn on your microphones at the end and ask questions. So we're looking forward to a really excellent presentation and excellent discussion. So thanks, Naomi, and thanks, Shanee.
Thanks, Paula. All right. Hi, everyone. Thank you so much for joining this afternoon. So my name's Shanee. As Paula said, I'm a final year med student, and this year I completed my thesis on the topic of what matters most, a legal ethical analysis of reasonable inquiries in obstetric care. So I'd like to say a very big thank you to Naomi for presenting with me today, and also to both Naomi and Paula for their supervision with this project. I would also like to start by acknowledging the traditional custodians of the land on which we meet today. So I'm zooming in on Wurundjeri land of the Kulin Nation, and I'd like to pay my respects to the elders past and present. So just by way of overview, I'll start by providing an introduction to our research with a patient case, and then we'll also just quickly go through the research question and aims of our research before moving into some background information where Naomi will speak about birth trauma, and I will go into the legal, professional and ethical obligations of doctors. We'll then talk about the problem that we've actually identified with our research, as well as some solutions that we've posed. And finally, Naomi will speak about the limitations of our research. So the following story was obtained from the Birth Trauma Australia blog, where women share their real lived experiences with birth trauma. Karina is a registered nurse who found out that she was pregnant just before the COVID-19 lockdowns. Her pregnancy was complicated by a number of blood clots, and she also developed preeclampsia later in her pregnancy, which is a significant complication of pregnancy. She was required to have an emergency cesarean section as opposed to a normal vaginal delivery. And this was performed under a general anaesthetic, which is not typically the norm. So Karina had a number of complications that occurred after her delivery. She was required to stay in hospital for about 2.5 weeks, and she had quite a traumatic experience. Now, Karina later developed post-traumatic stress disorder, and she wrote, "The major trigger was not being listened to or having my concerns respected. Because I didn't have my baby in the room with me, it felt like I didn't matter." So Karina's story raises some really important questions. Were parts of her trauma preventable, and what obligations did we as doctors have to understand what mattered most to her? Unfortunately, experiences like Karina's are not uncommon. So our research has sought to answer the question, should obstetricians have a legal obligation to make their reasonable inquiries about what is significant to patients as part of the duty to inform? Now, the aim of this is to reduce the prevalence of birth trauma in Australia by improving doctor-patient communication. I'll hand over to Naomi now, who will speak a little bit about birth trauma.
Thanks, Shanee. So birth trauma is a woman's experience of interactions and or events related to childbirth that cause overwhelming, distressing emotions and reactions, leading to short and or long-term negative impacts on women's health and well-being. And that's a quote taken from Lineweaver from 2022. And birth trauma can include both physical injuries as well as psychological harms that occur during pregnancy and childbirth. And examples of physical injury can include hemorrhage, infections, damage to surrounding organs like bladder, for example. It could include incontinence experienced after birth, some nerve damage as well. But there's also psychological injuries, and some of those can include post-traumatic stress disorder, perinatal depression and or anxiety, and obsessive compulsive disorder. So in this presentation, we're mainly referring to psychological birth trauma. But it can be obviously related to concurrent physical birth trauma as well. Some risk factors for birth trauma include antenatal factors like pregnancy complications, like in the story that we just heard about Karina, previous mental health issues, a history of trauma or sexual abuse, unplanned interventions, and labour complications. Some less obvious risk factors in the perinatal period include poor healthcare provider communication, a sense of loss of control or autonomy, poor informed consent, lack of support or access to services, including debriefing services. And the literature demonstrates that it's a woman's subjective experience of her care, not just the objective medical events, that determines whether they have found a birth traumatic. And approximately 1/3 of women giving birth experience trauma, which is thousands of women. And the impacts of birth trauma can be both long-standing and widespread, affecting them, their infant, their family dynamics, and the broader healthcare system. We know that women who experience birth trauma have a 74% increased risk of developing postnatal depression, and 10% of women who experience birth trauma will develop post-traumatic stress disorder. Recognising this, in 2024, an inquiry by the New South Wales government received over 5,000 submissions from both mothers and the care providers in maternity care that was used to produce a list of recommendations aimed at improving the experiences of birthing women. The report highlighted a number of problems, including problems with the delivery model of maternity care, lack of trauma-informed care, problems with communication and antenatal education, the birthing environment overall, workforce challenges, and finally a lack of inclusivity, just to name a few of the issues that they identified. And the report found that, and they had about 5 findings, but I'll quote the first, which was that there are a number of individuals who have suffered preventable birth trauma in New South Wales. And the experiences of the people who gave evidence to this inquiry are distressing and unacceptable. And off the back of that, there were 43 recommendations made, and several of these referred specifically to the need for research into legislation regarding medical negligence and the birth experience. And that's what we're going to focus on a little bit today. So birth trauma represents a significant issue for patients, their families, and care providers, and it's a problem that's heavily influenced, although not solely influenced, by doctor-patient communication in maternity care. So one important way that we can improve communication and care is to work towards a better understanding of our patients' goals and values. And we can do this by listening to patients and by asking them about their goals and values. We can proactively seek to understand what matters to them and what information is significant to them when making decisions about pregnancy and birth. And while there's clearly a legal and professional obligation to respond to the concerns and questions that patients raise and that they bring to us during our consults, we argue that a more proactive approach is needed and that care providers should ask patients throughout their pregnancy and birth journey about what is important to them. I'll let you take over, Shanee.
Thanks, Naomi. So moving on, let's start by discussing legal obligations for doctors. So we know that doctors have legal obligations under the law of negligence when it comes to diagnosis and treatment and information provision. So the landmark case of Rogers and Whittaker established the legal standard for information provision. Now, this requires doctors to inform patients of material risks, which are risks that either the reasonable person or the particular patient would deem significant. Specifically, Rogers established a two-limbed test for materiality. So there's the objective limb, which is what the reasonable person would consider significant, and the subjective limb, which is what the particular patient would consider significant. So in a medical context, a objective risk might be something like infection or death, whereas a subjective risk would be something that is more particular to that patient. So potentially mental health risks or other complications that might affect their day-to-day life. So our research has focused specifically on the subjective limb of materiality, specifically how doctors ought to determine what might be significant to the particular or unique patient that they are treating. So there was a brilliant paper by Addison in 2003, which sought to sort of categorize various different factors that the courts have considered in constituting a material risk since Rogers. So there were a number of different factors, but the most sort of relevant to our discussion are likelihood and gravity of the risk, necessity of intervention, and most importantly, a patient's desire for information. So this last point regarding the patient's desire, to understand and know different risks was reaffirmed by cases in the following years. So there was Chappell and Hart, B. and Marinovich, Johnson and Biggs, and Rosenberg and Percival. And this really tells us that the courts value how much the patient desires to know quite significantly when it comes to material risk. However, despite requiring doctors to inform patients of material risks, the law in Australia does not outline how a doctor should identify what may be material and thus of significance to their patients. So there are no cases of maternity care and information provision that we were able to identify in Australian law. So we turned to the UK. Now, for those who are not familiar, the case of Montgomery and Lanarkshire, which was heard in 2015, was a case about a woman, Mrs. Montgomery, who was a particularly small woman who had type 1 diabetes. Now, this increases her risk of having a larger baby, something that we call fetal macrosomia. So when a woman is pregnant with a baby that is larger, this increases a risk of something called shoulder dystocia, which is when the baby becomes stuck in the birth canal during delivery. So Mrs. Montgomery, despite letting her obstetric care provider know that she was quite concerned about the size of her baby, was not informed of the risk of shoulder dystocia and was also not informed of the option of a caesarean section to mitigate this risk. Unfortunately, when she proceeded with a normal vaginal delivery, a shoulder dystocia occurred and the baby was deprived of oxygen for about 12 minutes. The baby was left with severe disability, so this included cerebral palsy of all four limbs, and was an example of a particularly poor outcome for a patient who expressed a continuing desire to understand the risk that was posed by her baby being large. So what did the court say? The court held that Mrs. Montgomery should have been advised of the risk of shoulder dystocia as well as the option of a caesarean section. Now, the court's finding brought the UK common law in line with Australian law through rejection of the Boland principle and establishment of a test of materiality in line with Rogers. Lady Hale also criticised the act of medical practitioners disguising their own value judgments as medical advice. And she made a particularly poignant statement. Gone are the days that on becoming pregnant, a woman lost her right to act as a genuinely autonomous human being. So what can we actually make of this case in the context of our research? Now, while Montgomery demonstrates rejection of medical paternalism and support of patient autonomy in childbirth, it does not actually extend the subjective limb of what constitutes material risk. This is because it doesn't actually require doctors to make inquiries about what is significant to the patient, but rather just to respond to the patient's desire for information. Additionally, it also hasn't been referred to by Australian courts, so is not part of Australian common law. So now we'll have a look at the professional obligations for doctors. So professional obligations are described by the Doctors' Code of Conduct, and APRA is the regulatory body that actually enforces this code. So the code establishes a professional requirement for doctors to understand and respect their patients' views, concerns, and preferences under section 4.3.1. So this tells us that doctors ought to be making inquiries about what is important to their patients. Now, while some doctors may already make these inquiries, and I know I've certainly seen this during my own experiences in the labour wards, we can see from the birth trauma literature that this is not being done reliably, that patients are reported feeling unseen and unheard and like their views and values don't matter. And what we can see is that the current legal and professional obligations in place do not adequately support patient care and autonomy in maternity care. So it's important to consider as well the differences between a legal and a professional obligation in this context. So a key difference is that a key difference between legal and professional obligations is the possibility of compensation for patients who are harmed. So when a doctor fails to meet their legal obligations, patients can seek compensation in the form of damages through litigation. So in the context of birth trauma, for example, this might include access to financial resources that would support them in seeking ongoing mental health care, inpatient psychiatric admissions, perinatal care, lactation support, as well as a plethora of other resources. However, importantly, patients cannot access compensation unless there is a breach of the standard for a legally recognised obligation that has caused them harm. Comparatively, when doctors fail to meet their professional obligations, patients cannot seek any form of compensation. So in this case, under the Health Practitioner Regulation National Law Act, the medical board can place restrictions on a clinician's practice, they can remove their registration, or they can fine them up to $30,000, but none of this money is actually payable to the patient. So this gap is really important when we consider patients who experience birth trauma, because when doctors fail to make reasonable inquiries about what is significant to their patients, these patients may be inadequately informed of material risks and subsequently unable to access compensation if they experience harm because of it. So now we'll have a look at ethical obligations. So the importance of ethical obligations, of reasonable inquiries, is reinforced by a doctor's ethical obligations. Now, these obligations set the goalposts for clinical practice, and often codes of conduct are based on underlying ethical principles. So ethical obligations can be used as a guide for future codes and clinical guidelines. Doctors have a duty to strive for moral excellence. This is because of the inherent power imbalance that exists in the doctor-patient relationship. And this informs how doctors should approach patient autonomy in medical decision-making. So doctors should strive to uphold patient autonomy to the highest degree possible, particularly when it comes to high-stakes decision-making like childbirth and labour. Now, this doesn't mean that the standard must always be achieved, but emphasis is on the word strive, in that doctors should always be making good faith attempts to try and achieve this level of moral excellence. Meaningful choice, which is integral to a patient's autonomy, requires a patient's choices to reflect their values, not just medical facts. And so to provide appropriate information, doctors must understand what matters to their patients. So if obstetricians are not required to contextualize information within a patient's personal values, then these birthing women will remain vulnerable to experiences that increase their risk of birth trauma. So now that we've identified legal, ethical, and professional obligations, let's knit the problem together. So from an ethical standpoint, we can see that there is a clear obligation for doctors to be making reasonable inquiries to best uphold patient autonomy. However, we know that there is no clear legal obligation for these inquiries to be made. So this means that patients who are harmed because of a lack of inquiry are not able to seek compensation. We can also see that a professional obligation to make inquiries about what's important to patients exists, but this is not being done reliably in obstetric practice. And because of the nature of professional obligations, these patients cannot access compensation for harm caused when a doctor fails to fulfill these obligations. So overall, this demonstrates that the current legal and professional obligations in place do not provide an avenue to consistently ensure meaningful choice for patients in a way that would prevent birth trauma. So now that we've identified the problem, we can start talking through some solutions. So creation of a new legal obligation would make the law more autonomy enhancing and bring it in line with professional and ethical obligations. Creation of a new legal obligation would also give patients who experience harm access to meaningful compensation that is proportionate to the magnitude of harm that they experience. However, we know that the law can be very slow to change, and when we consider the magnitude of this problem, 1/3 of people giving birth experiencing birth trauma, we need a more timely solution. We can also see that current professional obligations require doctors to understand their patients' values, and these are not being consistently implemented. This tells us that we need a clearer guideline to outline appropriate standards of inquiry for doctors. This would also better support doctors in meeting their ethical obligations, which reaffirms the importance of reasonable inquiries. So, to bridge this gap, we propose that a discussion about patient goals and expectations should be embedded in standard antenatal care. Fortunately, there is a previously established and widely used model termed goals of care. So this involves understanding what a patient wants to achieve during an episode of care within the context of their particular clinical situation. So when we think about maternity care, goals of care might refer to set ideas about pregnancy, labour, intervention, or perinatal care. And if this is effectively adapted to meet the needs of maternity care patients, we could better facilitate discussions between doctors and their patients about the patient values, which is central to the issue we've identified. So through implementation alongside the standard antenatal history, which requires us to understand a patient's medical history, parts of their social history and psychological history, we'd be better able to recognise when a woman's goals might be challenged by clinical circumstances. So for example, if a patient is particularly adamant that they don't want to have any form of medical intervention, it's important for us to know these things at the beginning so you can better engage with that patient and prepare them for possible situations that may arise. So we've proposed that the standardised goals of care form should be completed at 4 points in the patient's care journey at a minimum. So firstly, at the booking visit in early pregnancy, as well as the 20-week visit and 36-week visit. We've also proposed that this discussion should be happening at admission or at the commencement of labour, if possible, to provide patients with dedicated time to explore their goals as they develop or may even shift across the pregnancy. So there are a number of benefits to this kind of implementation. So this provides doctors with formal documentation of reasonable attempts to understand what is significant to their patients. So this is possibly not only legally protective for doctors, but also improves communication of patient goals between care providers. Other benefits that we've identified relate to issues that have been identified specifically in birth trauma literature, so improving doctor-patient communication as well as communication between the care team, early opportunities to identify misunderstandings and potential challenges in care provision. Finally, this model also increases opportunities for tailored antenatal education, which is central to providing patient-centred care. So now let's come back to Karina's story, who we spoke about at the start, and take a look at how things might have been a little different for her. So we know that Karina's pregnancy complications already increased her risk of birth trauma, but beyond that, let's consider what mattered most to her. So having a goals of care discussion at Karina's booking visit could have allowed for early identification of her desire to be explicitly included in decision-making and feel like a part of her care team. With her background as a nurse, she may have appreciated different forms of communication. Given Karina's complications with a number of different blood clots, revisiting her goals after this happened could have allowed for more proactive discussions to prepare her for potential emergent scenarios that did eventually arise. Clearer documentation of Karina's preferences would have informed her care team and people who are coming in, later in her care, particularly at the time of her birth, particularly what was important to her in the context of a traumatic delivery. So while we may not have actually been able to mitigate all of Karina's trauma, there certainly is opportunity for improvement in her care. I'll pass back to Naomi now to discuss some of the limitations with our research.
Thanks, Shanee. So what we've proposed is certainly not a solution for all of the problems about birth trauma, but it does cover off, I think, a few things. I'll tackle increased burden and increased liability together. So I've never really liked the argument that just because something is maybe more time consuming and more difficult, that it shouldn't be done. I think people raise the same argument when we talked about when Rogers and Whittaker was first handed down, and when we talked about informed consent for participation in research trials back in the 1960s. So I think that communicating with patients is a really important part of our job. I think that it is the bread and butter of what we do. And I think also what we're talking about is bringing legal liability into line with professional liability. So what Shanee has demonstrated is that, you know, these discussions are already part of our professional obligations as doctors, and it's already what is expected of us. We've also demonstrated a way that it can be streamlined into the antenatal care schedule. We're not talking about extra appointments. And for many patients, this won't need to necessarily be a particularly long discussion, but it is still an important one. But there will be some patients for whom this is going to extend the time that we need to spend with them, or potentially increase the number of visits that we need to in order to cover this off. And I think that that is a burden that we should embrace. The goals of care is also already part of the national standards. So it's something that, you know, every hospital across the country needs to abide by. The goals of care is on the front page of all of patients' histories, and has been since I was an intern. So again, we're not reinventing the wheel. What we're asking is that we integrate this into a complex care pathway, which is maternity care, in a way that that already aligns with an antenatal care schedule, where we see patients quite frequently throughout their pregnancy and towards birth. I also think that it improves our documentation. So, you know, most maternity hospitals will have a way of documenting, and in a lot of Victorian hospitals, that is through the birthing outcome system. So that's a software package that you can design yourself. And so there are certainly very easy ways that we could integrate the documentation of these discussions so that it's readily available to any healthcare professional, be that another doctor or be that a midwife, that might open the file and then would like to investigate, you know, what kinds of discussions and where the patient's up to in terms of their expectations. In terms of compensation, the gap that we've tried to fill here doesn't necessarily address the problems in compensation, because what we're saying is that there really isn't a legal obligation to do this. So we haven't been able to successfully work out how to ensure that patients can be compensated, or can get some financial relief for the psychological burden that they experience. We've focused mainly on clinicians here, and we haven't really spoken about other healthcare providers. And I think something that came out of the birth trauma inquiry is that it's not just obstetricians, it's a whole host of different people that interact with patients throughout their pregnancy and birth. The other thing we haven't really addressed is quality control, because just because we say that there are these conversations that need to be happening with patients doesn't necessarily mean that they happen well. So there is some education and training that needs to be partnered with this solution to ensure that it's quality communication. It's not just a tick box exercise as we complete the antenatal care visits. And so some ways that we could try to do that is to ensure that, you know, there is some education opportunities. There are already those that are provided by the college. There are also internal ones that are sometimes provided by hospitals. We could do audits of completion, you know, in, say, BOS, the Birthing Outcome Systems package. There's also evaluations that we could do with patients to see if we can improve their experience. I guess that sort of leads me on to research. I think definitely more research is needed. And if we were to implement this sort of solution, making sure that we have a way of investigating whether or not it's been effective in improving the way that patients feel about their antenatal care, whether or not they're feeling that they're being heard, and if this has been of any benefit. I'll hand back to you to close, Shanee.
Yeah, thank you. So yeah, to conclude, it's clear that our current legal and professional obligations for doctors do not adequately support autonomy-focused maternity care. A new legal obligation would be beneficial, but this is probably not going to happen at a pace that is going to meet the issue where it's at. So we need better guidelines to help doctors meet their professional and ethical obligations in order to fulfill our to fulfill our ethical obligations. So implementing standardized goals of care discussions offers a practical solution for doctors to improve their communication with patients through inquiring about what actually matters to them, and could possibly improve the birthing experience of thousands of women Australia-wide. Thank you.
Thanks, Shanee. Thanks, Naomi, very much. That was excellent. So Shanee, we're right on too, but if you have like a final comment, Shanee and Naomi, for just 30 seconds, then we'll finish. Thank you.
Yeah, I just wanted to add, I think something that we considered when we were sort of working out the direction that this research was going to go in and what kind of solution we were looking at, was, I guess, what role does a legal obligation play? And one of the really interesting things that I read quite a bit about in the early stages of my research was this idea of defensive medical practice and how negatively it can influence clinical practice outcomes and the kinds of behaviors that it drives. So I think what we really wanted to focus on was, rather than being, I guess, punitive, is how can we actually enhance the types of communication that are happening and drive more positive behaviors from healthcare providers. So while, again, that doesn't bridge that compensatory gap, I think it focuses more on what is the underlying issue here and how can we actually work on improving what is clearly sort of a systems level issue. So yeah, that was my final.
Thanks, Shanee. That's excellent. And Naomi, any last comment?
I wouldn't want to ruin what Shanee just did in beautifully summarising, I guess, what the purpose of her solution today is. And so I think that for next steps for us is, can we actually implement it? Can we come up with some sort of goals of care form or something that we can actually start to integrate into care, into antenatal care, and see how it runs? And I'm excited to see what Shanee does next.
Great. Thank you. So thanks very much to Naomi and Shanee. And I just wanted to tell you that Shanee won the prize at the Melbourne Medical School Student Conference for her presentation on this research. So congratulations, Shanee. And thanks everyone for joining and for what was a really fantastic discussion. I hope everybody enjoyed it very much. And we'll be back next month with another Helen seminar. So we'll send around details. If you're not on our mailing list and you'd like to join, we've just popped a little link in the chat that you can use to register your details. But thank you again, everybody, for joining today, and thanks to our presenters.
Thank you.
Thank you. Have a good day.